Hello, my name is Lena Specht. I'm a clinical oncologist from Copenhagen, Denmark, and I'm also vice chairman of ILROG. And I'd like to talk to you today about radiotherapy in the treatment of lymphomas in older patients. These curves are the incidence curves for different types of lymphoma in the UK from 2004 to 2012. And as you can see, for most lymphoma types, the incidence rises with age. And in fact, for all lymphomas taken together, the median age at diagnosis is 67 years. This is in the UK, but it's typical of the situation in Western countries. So clearly, lymphomas is a disease of older patients. The definition of older has changed. Used to be 65 plus, now more likely 70 plus or 75 plus. And a new group, the oldest old, has been defined, 85 plus years old, which is the fastest growing age group in the US. In my own country, Denmark, the fastest growing age group is in fact the over 100-year-olds. So a growing group of patients. So the incidence of lymphomas is higher in the older patients, and the majority of lymphoma patients are in fact elderly. Their survival is significantly worse than younger patients, and they have significantly more comorbidities and tolerate treatment significantly worse. And unfortunately, the evidence for the treatment of older patients is sparse. Elderly patients are rarely included in clinical trials. The shorter survival in older patients is associated, of course, with advanced age, but also poor performance status, dependence in activities of daily living, and severe comorbidity. Our problem is that we do not know which patients will benefit from which treatment. With regard to Hodgkin lymphoma in older patients, well, this is a disease we normally associate with young patients, but in fact, the incidence curve is bimodal, and there is another top which has not gained as much attendance, which is in the older age group. But the over 65 years old are projected to account for the majority of the population growth and will constitute about 20% of the population in 2030 in Western countries, which is about the same as the age group 15 to 30 years. So Hodgkin lymphoma will be as common in the older age group as in the young patients in the future. And we have to get used to the fact that Hodgkin lymphoma is no longer just a disease of the young. The mortality curves are very different. The mortality is very low in the under 50s, whereas it rises steeply in the over 65s. So clearly there is an unmet need for treatment tailored to the older age group. Because it's not just that they die from old age. These are the age-specific 5-year relative survival curves for patients, for males and for females, according to age in the Nordic countries, so fairly typical of Western countries. And as you can see, in the over 50s, the relative survival decreases rapidly. So the survival of the patients here is much poorer than the general population when we get into the older age groups. There are many good Hodgkin lymphoma trials carried out, but often they are not directly relevant for older patients. Almost all European trials have limited eligibility for trials to patients less than 60 to 65. The important German Hodgkin study group has included patients up to the age of 75 in their early stage trials, but in fact, less than 5% were over 65 in the German trials. For poor prognosis patients, BRCA has been the main intensification tested, and this regimen is simply not relevant for patients over 50 to 60 because they don't tolerate it. For good prognosis patients, omission of radiation therapy has been the main de-intensification which has been tested, and this has been based on a scare of long-term complications from now outdated radiation techniques. And mostly it was a scare of second malignancies, which is less relevant for patients over the age of 50 to 60. And with modern treatments, this scare is also much exaggerated, which is borne out by this fairly recent study from a national study from Sweden, where they looked at the long-term mortality in stage 1A and 2A Hodgkin lymphoma patients treated with ABVD and limited field radiotherapy. And this is the cumulative survival, relative survival of patients with early-stage Hodgkin lymphoma. And as you can see, with a median follow-up time of 16 years, it was completely equal to the background population. So in conclusion, patients treated with 2 or 4 cycles of ABVD and 30 gray local field radiotherapy had an excellent relative survival, and so these results really contradict the rationale that you should accept a higher risk of relapse to achieve less toxicity. Toxicity is really minor with modern treatment. The systemic treatments are not easily tolerated in older patients. ABVD is a standard treatment for Hodgkin lymphoma, and in the German Hodgkin study group HD10 and 11 trials, which included favorable and unfavorable early-stage lymphomas, Hodgkin lymphomas, it is clear that the relative dose intensity achieved in older patients was much lower than in younger patients. The risk of acute toxicity grade 3 to 4 was much higher in older patients, and the risk of infections grade 3 to 4 in older patients was also much higher. And this resulted in a much higher mortality in patients over 60 versus the ones less than 60. Diomycine toxicity is a major problem in older patients that has been partly alleviated by the results of the British RATTLE trial, demonstrated that diomycin can be omitted in patients who are PET negative after 2 cycles, but still a serious problem, and at any rate, in general, a very much higher risk of serious toxicity in older patients. So there have been attempts to devise regimens that should be less toxic and still effective in older patients. This is a study of a gemcitabine-containing regimen which had seemed very promising, the PVAC regimen, but in fact, when it was tested, you only achieved a progression-free survival at 3 years of 56%, so not so good after all. A more promising study was this one published by Andy Evans et al., a phase 2 study of brentuximab vedotin and AVD in advanced Hodgkin lymphoma in patients aged over 60 in good performance status, and in this study, the progression-free survival was actually very nice, but only 52% of patients completed the treatment. Andreas Engel presented a study run by the German Hodgkin study group and the Nordic Lymphoma group at the most recent Lugano meeting, and this study treated patients according to their performance status and their geriatric rating scale with either brentuximab plus cyclophosphamide, idomycin, and prednisone, a sort of CHOP-like regimen, or brentuximab alone. It had seemed very promising, but actually the 1-year estimate of progression-free survival was only just over 70%. So again, not really that promising. The fact is there has really been no regimen proven to be less toxic in older patients and still effective for the treatment of the disease. There are new drugs, brentuximab vedotin, but it has a significant risk of neutropenic infections and neuropathy, which are both particularly serious and threatening in older patients. And in the large Echelon 1 trial in advanced Hodgkin lymphoma, where brentuximab plus AVD was tested against the standard ABVD, there was a significant benefit in the overall in the trial, but not in the patients over 65, where there was absolutely no difference. The checkpoint inhibitors are promising drugs in Hodgkin lymphoma, not so much a single drug as in combination, but they do have more grade 2 and 3 adverse events, and these side effects occur earlier in older patients, and there are still no trials yet specifically in older patients with these drugs. Radiation therapy, on the contrary, is very well tolerated by older patients in early stage Hodgkin lymphoma. In particular, modern, highly conformal radiation therapy, where we only irradiate initially macroscopic disease, so highly personalized treatment, only irradiating what is absolutely necessary, and to lower doses, 20, 30, 36 gray, depending on risk factors. And by using all the modern advanced and conformal techniques, we are able to spare the normal tissues in an optimal way. So acute toxicity is these days very rarely a serious problem, even for older patients. Late toxicities have, as mentioned previously, been a concern with radiation therapy, much less so with modern highly conformal treatments. But cardiac toxicity is one of the concerns. This is in particular in the patients with mediastinal disease. And the fortunate thing is that in older patients, Hodgkin lymphoma is rarely involving mediastinum and rarely with large masses. And with modern radiation techniques, the cardiac doses have been reduced very significantly anyway. And it must also be remembered that the systemic treatments are certainly also cardiotoxic, in particular, of course, the anthracycline. Another concern is the second malignancies. Now, the absolute excess risk of breast cancer, which is one of the most common second cancers, the absolute risk after chest radiotherapy decreases with increasing age at treatment, and is actually not, with modern treatment, a significant problem in older patients. The absolute risk of non-breast cancer does not decrease with increasing age at treatment, but there is a caveat here that the data we have derived from old studies with large radiation fields, a high prevalence of smoking, and heavy use of alkylating agents. And it's important to remember that the most likely second cancer in a Hodgkin lymphoma patient is in fact recurrent Hodgkin lymphoma, very important also for older patients. In early stage Hodgkin lymphoma, combined modality treatment is the standard. It was shown to be superior with regard to local control, both in the H10 trial by the AOTC, the UK RAPID trial, and the German HD16 trial. All these trials focused on avoiding radiation therapy, even accepting some more relapses on that account. And this approach in young patients relies on the availability of potentially curative treatment of relapse. That is, in most cases, high-dose chemotherapy and autologous stem cell transplant, which is not, by the way, that good even in young patients, as less than 50% achieve long-term disease-free survival. But it certainly isn't an option in the vast majority of older patients, because they do not tolerate this intensive treatment. And even in the few who can tolerate intensive relapse treatment, the risk of serious toxicities are high. So cure with the primary treatment is mandatory, in particular in older patients, because they do not have a good salvage option. Now, if we turn to non-Hodgkin lymphomas in older patients, the incidence and mortality curves are very straightforward, with a very steep increase in incidence both in males and females, and also in mortality. So here really the major group of patients are in the older age groups. With regard to the aggressive lymphomas, and the diffuse large B-cell lymphoma is of course the most common one, the guidelines from the NCCN call for a non-bulky disease, either brief immunochemotherapy followed by involved site radiotherapy, or full chemotherapy with or without radiotherapy. For bulky patients, full immunochemotherapy is advised, plus or minus involved site radiotherapy. So these are the standard guidelines. However, this study by Vargo et al. Using data in a large number of patients from the US National Cancer Database demonstrated, this is of course not randomized, but it was done by propensity score adjustment to compensate as much as possible, and the data material is very large, and it demonstrated that there was a significantly poorer survival in patients treated with chemotherapy alone compared to patients treated with combined modality. Even so, the common interpretation of the randomized studies have been that they do not show a compelling reason to prefer short chemotherapy and radiotherapy in aggressive lymphomas, unless, and this is important, in particular for older patients, unless there is an increased risk of chemotoxicity or poor tolerance, which, as I demonstrated previously, is certainly the case in older patients. So for older patients, brief immunochemotherapy followed by radiotherapy, local radiotherapy by modern techniques, is certainly a much safer treatment for most patients, and with excellent local control and excellent survival. And this is borne out by this study by Oncology et al. Using the SEER database, where they could demonstrate that in patients over 65 years of age treated for early stage diffuse large B-cell lymphoma, the overall survival was the same whether or not radiotherapy was used, but the progression-free survival was significantly poorer with chemotherapy only as compared to the combined modality strategy, resulting in a lower risk of requiring second-line therapy and of neutropenia, fever, and being hospitalized for neutropenic fever. So a better quality of life and less risk if combined modality is used. And another study by Parikh and Yahalom, published in 2017, with almost 2,000 patients over 60 years in the US National Cancer Database, again propensity score adjusted, showed for early stage patients over 60 years of age a significantly poor survival of those who were not treated with combined modality but only with chemotherapy. So it is surprising, based on these data, that the use of radiation therapy is actually going down in early stage diffuse large B-cell lymphoma. This study from 2016 is a single institution cohort of 68 patients who were in complete remission after immunochemotherapy, and then they were compared, the two groups, whether they received additional radiotherapy or not. And as you can see here, the progression-free survival was much better in the patients who received radiation therapy, and also a marginally significant improvement in overall survival. And in this study, it was demonstrated that with radiation therapy, the local control was actually 100%. So older patients with diffuse large B-cell lymphoma localized are better treated with less immunochemotherapy and more radiotherapy consolidation, because they have higher chemotoxicity, more infections, hospitalizations, more cardiac risks, more neurological damage than patients treated with combined modality. The long-term concerns of radiation therapy are much less with modern radiation therapy, first of all, but also even if they occur, with the risks of modern radiation therapy, these are much less relevant for older patients. There is suboptimal local control with chemotherapy alone, and this is particularly important in older patients where there are few and more toxic salvage options. So both with regard to chance of cure, of quality of life, and of cost, the combined modality therapy of early stage disease is preferable. We then turn to the indolent non-Hodgkin lymphomas. The follicular lymphomas are the most common ones, and these are the guidelines from the NCCN, where for stage 1 with non-bulky disease, the treatment of choice is involves site radiation therapy, whereas for patients with bulky disease, some form of systemic treatment followed by radiation therapy is the preferred treatment. This is a study from ILROG, a multi-institutional study from different ILROG institutions around the world, looking at early stage follicular lymphoma in the era where they were staged with PET scans. So optimal staging, selecting out the patients who were most likely to be truly in early stage disease. And they were treated with radiation therapy, and as you can see here, the 10-year progression-free survival was just over 50%, and the overall survival was excellent. So the results of this treatment with the local radiotherapy in early stage follicular lymphoma is actually excellent in modern days with modern staging. The strange thing is that although for early stage follicular lymphoma radiation therapy is in the guidelines the treatment of choice, less than 30% of patients actually are treated with radiation therapy, whereas systemic therapies, which are less effective or low or watch and wait, has become increasingly popular, and this is really regrettable. Because radiation therapy is the most cost-effective way to treat indolent lymphomas. The treatment, again with modern highly conformal radiotherapy and also with the reduced doses, is now an even milder treatment than it used to be in the past. This is the large randomized trial from the UK lymphoma group, randomizing patients with indolent lymphomas, follicular lymphomas or marginal zone lymphomas, but mostly follicular lymphomas, randomizing them between the in the past the usual treatment 40 gray compared to just 24 gray, and demonstrated no difference at all with regard to overall response rate, local control, progression-free, and overall survival. So this was practice changing, and now the standard curative dose for follicular lymphomas and other indolent lymphomas is 24 gray. And this is because lymphocytes and also indolent lymphoma cells are exquisitely radiosensitive. Even low doses, just 2 gray times 2, that is a total dose of 4 gray, has been shown to be extremely effective because it activates the p53 pathway leading to apoptotic cell death. This has been extensively investigated by Rigshospitalet in Amsterdam. Over here you can see a Giemsa stain smear from a lymph node containing follicular lymphoma. This one was before radiotherapy, and this one was after radiation therapy with 2 gray times 2, that is a total dose of 4 gray. And as you can see, here are lots of viable lymphoma cells, and over here, after just 4 gray, there's massive nuclear chromatin condensation and apoptotic body formation. So very, very striking response. It is also demonstrated over here in an annexin V SPECT scan. Annexin is a marker for apoptosis. Up here before radiotherapy, you can see the lymphoma on the right side of the neck, which is sort of slightly positive. And after these 4 gray, massive uptake of annexin, demonstrating occurrence of massive apoptosis. So this striking radiosensitivity of lymphocytes and indolent lymphoma cells is certainly something we can exploit. And the British group then carried out a randomized trial, randomizing patients with indolent lymphomas, again follicular, mostly follicular, but also some marginal zone lymphomas, between the now standard dose of 24 gray versus just 4 gray for these patients. And the progression-free survival curves demonstrated that 24 gray is in fact superior. You have a higher chance of achieving local control with 24 gray compared to 4 gray. But 4 gray is still quite effective, and about 2/3 of patients achieve long-term control with just 4 gray, and the overall survival is the same. It demonstrated there was no difference in the treatment effect with regard to the size of disease, treatment intent versus whether it was curative or palliative, performance status, stage, time from diagnosis, and FLIPI score. And this is a very interesting phenomenon which can be exploited. And here I'll show you a new paradigm for treating patients with disseminated and selected localized indolent lymphomas, which was pioneered by Dr. Yahalom at Memorial Sloan Kettering Cancer Center, but is now being used in many centers, including my own, where we give to localized indolent lymphomas just 2 gray times 2, disseminated or localized, but actually for all disseminated, just 2 gray times 2. Then we wait for 2 months, evaluate the response. If the patient has achieved a complete remission, then there's no need for any more treatment. If the patient has not, if the patient is one of those 1/3 of patients who are not achieving complete remission, you can just easily give the standard curative dose of 24 gray in that same location. In this way, 2/3 of the patients are actually spared any more treatment and can do with just 2 gray times 2, which is an excellent treatment, in particular for older patients, because there's absolutely no toxicity and a good chance of cure. So low-dose radiotherapy, this boom as it's called, 2 gray times 2, is a highly effective, totally safe, easily delivered and logistically sound approach to achieve much with very little. It is superior to observation and waiting for progression or transformation. It doesn't close the door for a potentially curative dose if necessary. You can easily give 24 gray after 4 gray in cases where you don't achieve a complete remission. It is not immunosuppressive. It's not myelosuppressive. It is also not exciting like testing another phase 1 drug, but it is much less expensive. It's not financially toxic, neither to the individual nor to society. So we think that this should be listed in guidelines as the best choice for many patients with indolent lymphomas who require local control for palliation, and even in selected cases for patients treated for cure. And this is in particular true of geriatric patients who can be treated without any side effects, very brief treatment, and very few visits to the clinic. So many important possibilities of treating lymphomas in older patients, taking advantage of the excellent properties of modern radiation therapy. So I'd like to thank you for your attention. Thank you very much.